Good afternoon, everyone. Myself, Dr. Shikha Satyarthi, PG second year from Darbhanga Medical College. My topic is hemangioendothelioma, bridging benign and malignant. I have no financial disclosure. Chief presenting complaint. A 72-year female came to IOPD with chief complaint of a mass growing over lower eyelid since 1 year. She complained of bleeding from surface of lesion on and off since 2 months. History of presenting illness. My patient was asymptomatic 1 year back. Then she stated that the lesion started as a small swelling over lower eyelid, right eye, which gradually increased in size, associated with on and off bleeding from the lesion since 2 months. Past history. History of ascites, both eyes since 5 years. No history of trauma, no history of diabetes and hypertension. No significant family and drug history. Ocular examination. Visual acuity 618 both eye. Right eye eyelid showed a reddish globular mass, non-tender with smooth surface on lower eyelid. Conjunctiva was within normal limit. Cornea was clear. AC was quiet. Pupil was normal size and shape reactive to light. Lens was pseudophakic. Fundus was within normal limit and the extraocular motility was full and free in all gauges. Examination of mass. On inspection, shape was found to be globular, color reddish, location at the junction of medial two-third and lateral one-third, lower eyelid in right eye. On palpation, consistency was found to be firm and solid, non-tender, surface was smooth with no ulceration, mobile but attached to lower eyelid with a stalk. Excisional biopsy was done and the biopsy report showed the blood vessels lined by the plump endothelial cells, sheets of neutrophil, lymphocyte and macrophages were seen, and the features were suggestive of hemangioendothelioma with superadded acute and chronic inflammatory cells. These are the histopathological examination pictures of the excised mass showing hemangioendothelioma. Excisional biopsy was done and the patient was on follow-up for the recurrence. These can be the differential diagnosis. Case discussion. Hemangioendothelioma comes under the category of vascular tumor, which are the tumors of blood vessels and lymphatics. It can constitute a spectrum from benign to locally aggressive neoplasm. These are the classification of tumors showing hemangioendothelioma coming under the category of intermediate grade. This is one of the articles showing its rarest entity. Very few cases have been reported so far in the eyelid. Hemangioendothelioma is a heterogeneous group of borderline vascular tumor with intermediate biological behavior. Hemangioendothelioma is a heterogeneous group of borderline vascular tumor with intermediate biological behavior. It usually occurs in liver, bone, lung, and skin, but the rare form is seen in the eyelid. It has three subtypes: epithelioid, which is more aggressive, followed by pseudomyogenic, and hobnail. Epithelioid hemangioendothelioma is located in most probably in the lung, liver, and bone. Approx 50% are associated with blood vessels, most commonly associated with medium to large sized veins, causing venous occlusion. Clinical course is variable. Treatment is excision. Prognosis: 40% may reoccur, 20 to 30% may metastasize, 15% may lead to death. Immunohistochemistry shows CD31 or CD34 positive. Pseudomyogenic, also known as the epithelioid sarcoma like hemangioendothelioma, most commonly affects male. Peak incidence at 30 years and recurrence after excision is 50%. Metastasis is rare. Hobnail refers to two closely related tumors, retiform and the Dabaska. Both contains cuboidal and endothelial cells with a high NC ratio. Both develop as poorly circumscribed plaques with an overlying violaceous hue with low-grade lesion. Thank you.
Yeah, I think the recurrence rate is very high. It goes up to 56%. And apart from surgery, you may have to use radiation also. There's one case reported in upper eyelid and forehead in a 78-year-old female.
Thank you.
Yeah, since it's localized, you can do cryo. If it was involving a wide base, then probably.
The acquired vascular lesions of the eyelid, I feel, are very challenging to treat because once they bleed so much, once you cut the base and you are not able to, you can't able, you're sometimes not able to see where the bleeding is from because sometimes they're so large. This one was very, it has a pedicle, but sometimes, they're very tricky to
There's a
deal with.
solution, you can use glue to prevent the bleeding.
Well, it bleeds so much that whenever you put glue, it just washes off. I have tried glue. So what I've started doing is, if there's a large lesion, I will just take a flap beforehand and put a flap and then keep it pressed over the lesion.
I think in my experience, almost all the vascular lesions which I've handled more than 100. So they all respond to immediate glue. Depends how you're using the glue. Are you diluting it with lipid oil?
No.
So you just inject it, solidifies there and then within seconds.
Okay.
Within seconds it happens.
Right.
So
So maybe I need to come and learn from you, from PJ. So do you have
anyways,
any comments?
Also, there is another trick. Like my mentor used to do it. My mentor, Dr. Santosh Kunal, he used to first put a traction on the tumor with the help of cryo. So you are not touching it with the forceps.
Mm-hmm.
So that way you are not disrupting any capsule wall. In that way, from the periphery, it cannot bleed. Once you apply a traction with a cryo probe, you need not to use any tooth forceps for that. And then after that, you apply a artery clamp. Over it, you do the RF pulgration. That's how you excise the tumor, not with the scissors, but with the RF pulgration, you excise the tumor.
Well, that's a great point as well. But few of the cases I have had, they have diffuse involvement of the lower eyelid, which was acquired. They were all young males which were previously diagnosed by someone as Kaposi's sarcoma, but they turned out to be acquired eyelid hemangiomas. So it was very challenging for me to just excise them, and it kept on bleeding, and then there was a reoccurrence after 3 months. So,
okay.
well, very good case.